Welcome to another episode, Medics and Data. I'm your host, David Andai, and today we have another topic, paying for artificial intelligence in medicine. Welcome, Doc. Niambie, watu wa pwani si Kenya. How are you doing?
Uh, Please stop calling us that before the government takes you seriously. So lately or recently, we've been looking at regulatory AI. We looked at the Pharmacy and Poisons Board guidelines on AI. Rather, what's that? MDSW. Kindly remind me the name, the full the meaning of the acronym.
Actually, it was the guidelines for the medical and software and digital devices, something like that, from PPB. And then within it, they had a layer now for AI because they also have a layer for cybersecurity, other software systems, and then within it, there's a section for AI. I remember section 2.8. I can't forget.
So we looked at the guidelines and how they affect current businesses in the digital health landscape, and how they better position themselves so that they can not only comply but also gain maximally from the framework. Then we also took a look at the new Kenya AI bill that has been
Mm,
presented on the floor of the Senate. Already first reading has happened. We try to now merge the two, how they affect businesses and what they are going to mean for those who are deploying AI in high risk category, which is the medical field rather. So yeah, we've looked at that. Now we are coming to look at how do you pay for AI. We have looked at the regulatory aspect of it. Now we want to look at is it the finance? Is it the economics?
mm.
The economics a bit of it.
I think, Doc, it's interesting because as we will see, I think as we go along, when you mention even the category, the high risk. So if I can remember well, I think this was category 4. So we see that there are different categories of AI tools in medicine. I think category 1 was AI tools, for example, that just offer education kind of things. I think category 2 was more of an integration with a human in the loop, and then 3 was more on medication, something that can alter medication and kind of stuff with human in the loop. And then number 4 is like no human in the loop, so the risk is even more high. So even if you look at those 4 categories, you can even think of, okay, there perhaps might be an implication on how the payment for these categories need to be considered, because something with a high category for a user, uh, perhaps the cost might be high. But I think also the most important thing for our setting, we've always been saying we want AI to be integrated in medicine, in healthcare, in Kenya. We want it to be used in a point of care services and systems, clinical decision support systems. Then the question becomes, okay, given that an AI is in this space, who is to pay for that integration? And there are a lot of ways to talk about this. One way, for example, you have mentioned is the regulatory way. Maybe I can start maybe from the infrastructure way place. So what I'm thinking just from the top of my head is that in these spaces, you need to install AI, some AI platform or something. So the infrastructure needs to be there. So who will pay for that? Where will the costs eventually go? Will it be on the patient, on the hospital, on the maybe insurance provider, as we'll see along in this paper as we go along? So again, those are some of the interesting bits that are there to explore. So yeah, any words before now we dive deep? I know this paper is interesting, but
No, I've been thinking as you
Mm,
mentioned the infrastructure bit, and I wanted to also mention the model of payment, because when you say the infrastructure bit maybe has been taken care of or is what you're paying for, maybe cloud storage for your data, stuff like that. Uh, what we need to also, what we are going to talk about also is the models of payment, because it doesn't
Mm,
just stop at infrastructure. And what is the risk of having one model of payment over the other? Like what you've just mentioned, I'd call it maybe pay per use sort of model. So we look at these models that are existing right now, the models that have been acquired or that are being utilized by insurance companies that are covering these devices, and the models that also other third party guys have acquired who are not necessarily directly involved in the deployment of these devices, but one way or the
mm,
other they're included, or they play a part. For example, the builders themselves, the sellers themselves, right? So yeah. Thank you. Let's
yeah, a good dog. So I think this paper is based in US. The paper is titled "Paying for Artificial Intelligence in Medicine." It's in a digital medicine journal. So I think just going somewhere where we've also started talking about is we were trying to tease out the categories of AI applications, and in this case they group it into, for example, like three sections. We have classes. I mean, we have assertive, augmentative, and autonomous, and they are alluding that that can influence how AI is reimbursed in this clinical setting, because necessarily or because of the benefits they bring to the patient. And in this case, we can think of, for example, the way, for example, a radiologist might approach integration with AI by having AI doing the initial screening and the radiologist reviewing later, thereby reducing time. So how then do we,
how
do
do you
we
quantify that time? How do you
exact
how do you quantify it in economic terms? Like
exactly.
yeah, these are conversation I realize we are not having a lot of this. We are just
Uh-huh.
assuming the cost is at the infrastructure level and then that's it. I've realized a lot of guys are not really looking at this thing.
Mm,
There are some, how do we call them? Intangible factors that you cannot really see or touch, but they end up maybe improving diagnosis, reducing patient wait time, and things like this
mm,
that really translate to, because if you really reduce patient time, I'm assuming if it's volume based, then the higher the volume of patients you can be able to see in a day, in a week, in a month, and be able to convert into that into economic profits. Now you look at that, how do you tell that it's these few AI devices that have translated that, and how do you compensate for the time saved? So yeah, I think it's interesting. It's interesting.
mm. And also,
Mhm.
just as you've mentioned, from the point of view, not thinking about these things, I'm reading this paper and I'm realizing the US actually had to sort of, let me say, announce its intention now to provide coverage for the first AI-specific common procedural terminology code and the creation of the first new technology add-on payment, NTP, for an AI device. So you see, it even comes from a point of policy, and they sort of, how can I put it? They pave way for the reimbursement of these AI devices. And then over here in this paragraph, now they go ahead and say reimbursement policies are important means of disseminating the benefits of AI across healthcare system. So I think we need, okay, in our case, quote unquote, our FDA might, for example, be PPB. They might have set the space in terms of adaptation of these regulatory benchmarks or criteria that are out there. However, given now that they have acknowledged the use of these AI devices within this space, then we probably need something that acknowledges the reimbursement. of these AI devices in this space. And for our case in particular, I remember there's a paper I was reading, it was from Nature. They were asking the use of AI devices, how can we quantify that they have improved, for example, healthcare outcome? So in our setting, do we say it's because of either time, either reduced mortality or morbidity, or like what is that outcome that we can link given the deployment of AI and a health outcome within our healthcare system? And then can we use that as a criteria of, given that we are seeing these benefits, we can be able to reimburse AI? And the reason I might say why this conversation maybe hasn't started that much in our setting is because of quote unquote lack of structure in, you really can't identify where the benefits are happening. For example, let me give an example of where, for example, the benefit can be visible. So, for example, in a hospital that only has, for example, three medical officers or three doctors, when you increase the number of doctors to, for example, 5 or 10, maybe you might see a reduced incidence of maybe patient deaths because they are being attended to these doctors. So then you can say, given the cost of employing these additional doctors, we have seen a reduction in mortality, for example. So in the case of AI, now when we plug AI into this system, can we say, okay, given that AI has been deployed in the system, we can see a reduction on A, B, C, and D, right? So now we can now speak of what is the current state of, for example, AI reimbursement in healthcare within this space. I know in our space, for example, that, as I've just mentioned, it is non-existent. But in this paper, we'll sort of borrow from or get ideas from what this market from the US is trying to do, or they are trying to look at. Some of the, just as I prepare you in, some of the AI devices that are reimbursed by US Medicare. In our case, we imagine, for example, SHA. You can see here there is digital diagnostics, which uses IDXR DR technology. So this one is a deep learning algorithm to diagnose diabetic retinopathy from fundoscopic images in outpatient setting. So in this case, I can imagine we have very many patients, and you want to reduce the time in which you are reviewing the fundoscopy results. So this digital technology can assist. And in this case, in US, that service is being reimbursed by Medicare. Something else I can see here is Viz.ai by Vizliv LVO. So this one is a radiological computer assisted triage and notification software that analyzes CT images of the brain and notifies the hospital staff when a suspected large vessel occlusion is identified. Again, somewhere where you expect large volumes of medical documents that need an eye by a doctor or any other clinician or another medic, then AI comes in this space. So given that AI can be used in this gap or in this clinical setting, then there is a formula in which it's being reimbursed by Medicare. Lastly, you can see the last column over here. There's that payment mechanism, the CPT, NTAP. So I think I mentioned the NTAP previously, and then you can see the year reimbursement granted. All these have happened, let me say recently in 2020. So the question is, where can our market sort of come in and try and quote unquote copy paste this kind of formula, something like that. Mm.
So I'm going to cover a few things.
Mm-hmm.
Some will cut across what you've just said. I want to reiterate on what you've talked about in terms of uh, paying for AI, right? So it's crazy that this paper says by between 2015 and 2020, the FDA had cleared like 222 AI devices, and then the European Commission had cleared like 240. We are going to see very soon the PPB guidelines take root, and we are going to see some of the AI devices being cleared to operate in the country, right? Then now we have the Centers for Medicare and Medicaid Services in the US, which you have maybe compared it to SHA, maybe, or I don't know if that's what you say. Uh, it currently reimburses at least eight of them, eight of these devices. That's out of 222 in the US, that is. Between those 2 years, 2015 and 2020. That's like 6 years ago. You can imagine the number right now. So they made history by approving the first AI specific billing code and also the first new technology add-on payment from TAP. Now, the model that they acquired of paying for the new technology of billing is kind of flawed. It has a false equivalent in it where you compare software to hardware usage. Because allow me to refer. Uh, it pays, like the CMS chose to pay for AI per use, like pay per use. Uh, Now the authors in this paper argue that, for example, a traditional medical device like an MRI has actually a real marginal cost because when you use it, you consume actual physical resources. But something like AI, it's pure software. So if you encourage a pay-per-use model, then essentially you're encouraging an overuse of this software. And remember, AI is high risk. So that is the flawed um, area. So which brings us to now, what are the alternatives? Because the second flaw or error in billing like that, I'd say, is the moving target problem, where you have the AI costs decreasing over time because we have seen decrease in computing costs, decrease in cloud storage costs, and stuff like that. You cannot be charging on the basis of pay per use. Now that we agree on that, what are some of the alternatives of reimbursement? What are some of the other models that we should see maybe our market take up, right? Because I know we when we started this podcast, we said uh, the challenging bit is going to be conversion of the AI gains into an economic value. Therefore, you'll get to know how maybe you're going to pay for this device or charge for this device as a seller. So, what are some of the five alternatives that we should be looking at? Do you want to go?
Okay. Okay. Before I dive into that, there's this point that you've mentioned, and I think it even uh like I'm trying now to remember, like for example, in our setting where this might happen a lot, where for example you're using AI more frequently so that you get paid. And I don't want to try, I don't know if I should say this, but think about how, for example, our labs in the clinics in the labs, for example, are operated, especially in town centers. So when you come, you find a patient doesn't really need a test, just send them so that you can be reimbursed by the patient doesn't need that test, but because exactly, but they'll be eventually reimbursed by the insurance company. So you find that you end up, like for example, doing that over and over, and in this case it's not really ideal, you see. So for example, I'd imagine they won't do that, for example, for maybe MRI, because maybe for MRI maybe the indication might be exactly needed, number one. And number two, maybe they should be senior consultant who is supposed to make that request, you see. So once those strategies have been introduced, is that thing like sort of an approval from these senior consultants. So once that approval is made vis-a-vis, for example, a senior consultant, or SA registration number on that, then we can reimburse that service given uh, the consultancy from that person. So when you mention that point, so that I'm thinking, okay, so if these payments can sort of be linked to that mechanism whereby reimbursement needs to be, for example, approved by a senior, so and so, then to some extent it will make sense in one way or the other. So that's not like number one I was thinking. Yeah. Uh, so now to the paper. To the paper, they they tease out various mechanisms. One is, for example, the incentive outcomes instead of now volume. So, for example, as you've mentioned, instead of just let us say we have a button that says AI use. And let us say, for example, we are paying this button, we are paying this clinic via how many times they will click that button. So in this case, the incentive will be on the volume of how frequently does this clinic press this button, all right? However, they're telling us we need to switch that. So incentive should be now focused on outcomes instead of volume. Okay, so they say, for example, payers could offer higher reimbursements to healthcare providers for stroke detection AI devices if post-marketing studies continue to demonstrate a positive effect on validated quality metrics in stroke care, such as specific door to puncture targets for intervention procedures for patient. Exactly. So in this case, you can see that it's not really about the number of detection, but the convention of how this stroke patient, for example, can benefit. Again, at the end of the day, for our healthcare system is how can we make this work in our setting? When this AI is deployed, can we come up with, especially in our setting, can we come up with a criteria that sort of pushes towards incentive outcome more than volume? Mm-hmm. Any other point? We continue.
There's
Mm-hmm.
the aspect of maybe letting the health systems determine or capture AI's value with their own efficiency gains. Then
Mm-hmm.
now from there, you can be able to maybe negotiate with the device manufacturer and take up maybe, or if they're offering some rebates in a certain percentage. Like, I'll give you an example.
Mm-hmm.
We had there's an example here of a cardiac device manufacturer, sorry, offering rebates of up to 45% if a device needs revision after
Mm-hmm.
implantation. Okay, and there's another version of the same model where you have an antimicrobial catheter, uh, where a contract of an antimicrobial catheter where the vendor shares in the savings from prevented infections. So it's more of, I don't know if I can call it a guarantee. Like,
Mm-hmm.
hey, if this happens, you get this percentage, you get to share this percentage. In short, the manufacturer is trying to guarantee to you that for sure my device or my commodity or my product is this good. So I'm offering at this price. You see, it's almost the same as incentivizing outcome.
Mm,
Then we have the advanced market commitments. I think I have seen these with, I
mm-hmm.
don't want to call them hackathons, but
Uh-huh. Uh-huh.
yes, right? Where you have the X prize model. Like we have
Mm-hmm.
the government, I think there was a time I forwarded this application to you. They were addressing, was it matters to do with AI in agriculture, in food security, in in security, also national security or something. Did you see? Do you remember?
Mm-hmm. Mm-hmm. Yeah, yeah.
Yeah. Now you have an X prize model where you define a healthcare problem, attach a prize to it, and then award it to whoever solves it first.
Mm-hmm.
right? It's more, okay, this is the problem. Send us a proposition. Let's see your solution, right? Then the requirement is that the code can be made public for after the winner, of course, gets the prize, stuff like that, so that we can we can improve on this model as fast as possible and
As
be able to
possible.
get
Mm.
exactly maximal gains from it. Uh, I think a good example where we saw these work is in the forecasting models or algorithms during COVID-19. Yeah, and we have seen them now since then in epidemiology circles. That happens a lot. Yeah, yeah. So take up the next one.
I think one now that I think I'm particularly interested in is the rewarding on interoperability and bias mitigation. So the reason I'm saying that is because AI in these spaces are usually approached as black box models. So by that I mean people don't understand like what really is happening. Yes, it is predicting so and so, but in this case, what is really happening for you to have that outcome. So in this paper, they've given an example. Let's say, for instance, you have an AI tool to predict sepsis that was based on data drawn from a single institution may fail to perform as well another clinical institution. So the idea here is that in the context, for example, of AI medicine, um, interoperability refers to that application ability of the AI results across multiple population, even when training data sets are drawn from different geographical domains. So in this case, you've seen that it is not interoperable, given that it cannot be used in, for example, different areas, and also there is sort of some bias that can be generated. So for AI that come with uh, sort of have this black box model kind of approach, number one, you don't understand what is happening, and then number two, for a certain area, it's not working as the way you'd want it to work. So given that you're not understanding what is happening within the model in itself, and you're not understanding if the results you're seeing is because of its failure being interoperable, meaning being used from one place to the other, then it becomes a problem. So one of the things here is that, okay, how can an AI device be interoperable and able to mitigate this bias? So if an AI is able to meet this criteria or this threshold, then we pay it. So that especially in our setting, that in a way it means that you can sort of reuse this AI across different populations. You can sort of even interrogate now the black box model in itself and look at it, because at the end of the day, there are two things are happening. It's either the model itself is going wrong, or in this case, there is no that interoperability and bias, maybe due to the population, something is happening within the variables and something you are missing. Or it can be even some human error or something like that that is causing that. So in this case, is sort of you sort of look it in two ways. Um, inter inter interoperability in terms of and bias mitigation in terms of it operating in different facilities, and in the sense that if it is not, then you really need to have an AI model that can investigate it uh, and see, okay, what's happening within this black box model. That's why we are having that kind of pattern. And then now third, that's when you reward those models that either are interoperable and bias function, and in this case, even those that you can be able to explain and especially even if it's in a national scale. And in our case, if you're looking at it from county perspectives, so looking from this county, this county, this county, so that's sort of like the way you can view how to reimburse these AI models. Any other two before?
So I think
Mm.
I would no, I was just waiting for you to mention the documentary that was done, uh, highlighting how Sha is a black box model, and I wanted you to mention it because you know you're the one who brought that Sha this idea today. So I was expecting you, knowing those qualities. for you to plug them in, or rather throw Sha into all those features. For example, the issue of
Mhm.
interoperability, the issue of there's this very good issue you've mentioned, validation. Yeah,
Mm,
like we saw the misclassification problem
mhm,
in that documentary. Guys were complaining about, the poor paying higher premiums, and the rich guys are paying lower premiums than they're supposed to. Yeah, we saw
mm,
how there is that issue of explainability where you get ranked or misclassified. You try to follow up to appeal. Your appeal is rejected because maybe the officers themselves who are in charge of maybe listening to your appeal do not even understand how their model arrived at what it arrived at.
mm.
Yeah, so they don't see a reason to to negate what the AI has said. And remember, in our last video, the one we talked about Kenya's new AI bill, we talked about uh, how it's going to demand you either as a professional, as a consultant, as the human in the loop to explain yourself why you went against uh, the decision made by that AI if anything wrong happens,
Yeah.
right?
Mm,
So you need to
mm.
have the knowledge of how this model actually works, right?
Yeah, yeah. I think now that they're mentioning that, even from the SHA perspective, let's imagine that now SHA is an AI model that is out there. You will find that it would be difficult for, let's say, SHA is not what it does currently. Let's say it's a model that, as you've mentioned, is used to investigate whether how much person A should pay, for example, towards, for example, the healthcare service, and it's making that calculation error. So another insurance company that's supposed to reimburse share would look at it and will be like, no, we can't continuously reimburse this service because it's perhaps doing a poor job, you see? And the way the person would know it, the insurance company would know share is doing a poor job is either by receiving multiple complaints from different people from different regions, like, hey, I'm from this region, I was charged this and this for this, and it doesn't make sense. Or two, by looking or investigating the model's components. And now this goes to actually one of the points that we were looking at now from the guidelines. The guidelines say once a model is deployed, it needs active monitoring and evaluation of those parameters, that you should have logs that consistently check how this is performing. So in this case, if you look into SHA and the logs are very off, then the owners of SHA will have a case to answer and say, okay, given the guidelines state this and this, why are they not meeting? And what did you do, for example, maybe to adjust the model parameters? Because models normally behave funny as soon as they hit the ground running. It might run very well, for example, during this period, and in the next period, just given some certain artifacts within the data, things might change. So that's an important way of how to consider even paying for these models in these systems in the first place. Something else now that is not in this paper that I was just thinking about is now when you want now to introduce AI devices into this space, there is that whole concept of either you are just doing it as I don't want to say it like a software, like an app. So remember the categories that you have: category 1, 2, 3, 4. In this case, because it won't really be impacting patient health, directly influencing, for example, management and all that, probably come in category 1 and category 2. So you have an app that you want to build and you want to send it to people to use. Then the question is, who pays for this kind of things? So in this case, you might have, for example, a subscription based where the user themselves pay for this AI device. Or number two, it can be, for example, a clinician. If a clinician is using this device for maybe to improve workflow, improve management, they might pay for it. Third, if it is a POS and a clinic wants to adapt this or a hospital wants to adapt this, then the hospital pays for the use of this thing. But number four, which is also important now, is when you want to do, let's say, large scale clinical trials of AI tools in healthcare and such of you, who then are the people who should pay for these kind of things? Do you look then for grants or from some sort of funding that pays for research of AI in medicine use? So again, that in that landscape, you have to think of paying for medicine differently. So in those four instances, you can see we haven't even involved the person from the insurance sector. It has just been either the user as a patient, the user as a doctor, the user as a clinic or as a hospital, and in this case, a funder, or in this case, might be a don through some grant application. I don't know if VCs can work in this case, who now come to pay for this tool to be integrated within the sort of quote unquote clinical trial design kind of pattern. Yeah.
Yeah, without forgetting, I think you, just as we finish up, I think all you're saying in short is we lack payment structure.
Mm,
As a uh, low and middle income country, call us a one country. As a low and middle income country, we lack a payment structure. So the biggest risk I think we face is underuse,
mm,
underuse. And I think the first teething problems we'll have to a lot of these AI devices in the medical field, especially the clinical setting, because I like how you have mentioned their particular use in different fields. Now, in the clinical setting, we'll have a problem when it comes to pay-per-use model. Why? It's the path of least resistance. It's the, you see, even the CMS guys did that mistake at first.
mm,
Because when you land in with a new technology, you'll find there is present technology, and you'll try to borrow some things from that present technology so that you can bring this future technology. And the first thing you'll borrow is the economic model, which is pay per use. And that is, at first it will seem to work, but it won't. So as we think about regulating these devices, let's think about the economic models to apply
mm.
when it comes to these devices. Yes.
Okay, and with that, I think I have the title for the podcast episode: Health AI Economics. Who should pay for AI in medicine in Kenya? So, so yeah, that's interesting. We'll see how it goes. I know some things will probably come up in the near future. Probably look up in that space and see what's coming. And yeah, and I think for that, it has been an interesting conversation. And to our audience, please make sure to leave a like, subscribe, and follow us in all our platforms. Yeah, here on YouTube, LinkedIn, Twitter. Do people follow each other in WhatsApp? Anyway, if they do, do that as well. It's been your host, David Andai, and my colleague here, Dr. Clinton Osebe. Until next time, bye bye.